It means that somebody is charging you not even a premium price, but a sort of like, well, just a crazy price.
Okay.
And anytime that's the case, it should raise a huge red flag. So.
And I think for me, the curing anxiety was a little frightening for me.
Yeah, well, it might cure the stomach acid that's coming up.
Okay. Okay, that's fair.
When you have anxiety, but it's not going to cure. I can't imagine how it cures anxiety. So
okay.
Now, with that said, there are plenty of procedures that started out.
Perfect.
Ready? Okay, we're rolling, and so just so you know, this is the generic camera, all three. This is just two of you. You don't have to look at this one, and that's Dr.
Boatwright.
So just keep a conversation. You don't have to look at the camera anytime, but just for the intro and outro.
Yep.
Address the camera. Ready?
Yep.
And 3, 2.
Hi, and welcome to Mind Your Health, where mind, muscle, mouth, and medicine converge. Dr. David Burke,
Good morning,
is so
Miss Debbie.
great to see you.
Thank you, my pleasure.
We have a wonderful guest today. Dr. Craig Boatwright has joined us, and we are really excited to begin a conversation about the spine. What do you think? Tell us a little bit, if you will, about your background, number one, and then how you became interested in this part of medicine.
Well, as soon as I open my mouth, it's evident that I learned to speak in South Georgia. So that's where I grew up.
Okay.
And after leaving South Georgia, I went to Emory University in Atlanta, and then I actually was fortunate enough to get a Rhodes Scholarship and went to England and studied at Oxford, where I read for a degree in human sciences. And then when I came back, I went to medical school at Harvard and then did a residency in Seattle at the University of Washington in orthopedic surgery, and then did a fellowship back at Emory. So,
when you first went into medicine, was the spine medical school and surgery something that you always were interested in? And I have to say that your children are scientists and opera singers, so genetically I think there's some interesting stuff in here with you.
yeah, I'm not sure any of that came from South Georgia.
Okay.
So,
now, don't discount that.
I'm not. Listen,
I can't spell opera in South Georgia.
Yeah, exactly. But I'm very glad I grew up in South Georgia, because I don't think I'd want to go back and live there right now. Mm-hmm. But I will have to say that the things I learned in South Georgia were very valuable. So how to work hard, and I learned a lot about doing farm labor, picking watermelons and things like that. But really, what I would say about, what was your question again?
Actually, my question was exactly that. Did you always want to be a physician, number one? Did you always want to be a surgeon, number two? Yeah. How did you kind of hone in your interests to the spine?
Well, when you grow up in South Georgia and you make good grades in science, they say, oh, you're going to be a doctor. So that's what your grandmother tells you too, right?
Right.
So, now, the thing is that when I went to Emory, I was all tracked on. I thought, oh, I want to be a doctor. And my main advisor at Emory, because I was, again, fortunate at Emory, what brought me to Emory was I was a Rhodes Scholar. So, and Woodruff is the guy who developed the Coca-Cola brand into the billion-dollar worldwide business that it was, and has given a lot of money to Emory. And he gave money specifically for scholarships. So it was one of those nice scholarships where they basically pay you to go to school.
What was your undergraduate degree in?
Biology and philosophy. So
philosophy?
Yes, because my advisor was a philosophy professor, and he was actually one of the world's experts on Sartre.
Okay.
But he was also a Catholic priest.
Oh, fascinating.
And I sat in his office and he said, Craig, you really should branch out a little bit from all this science and try some things other than science, liberal arts. And I did, and I liked philosophy and all the other things that went with liberal arts, all the classical stuff.
Are you a philosophy guy?
I think, therefore I am.
Of course. That's Descartes.
That's about where it ends right there.
Is that it?
That's
exactly.
Right.
All of my kids that I see are Marcus Aurelius, and so many folks are philosophy now. All right, but we're going to come back.
That stuff's a lot more interesting than the spine.
Well, it's kind of, I don't know about that.
Right, yeah.
Anyway,
So I went to Emory and I thought about some other things, but I always came back to medicine. Medicine is so interesting. There's so much to know, and then it's great to go to work every day and do something where you're helping people. So where the premise of the job is to help people.
So you went to Seattle, you did residency there.
Yes.
Orthopedic surgery. Then you honed that in even more to the spine. What is it about the spine that is so fascinating and interesting? And I asked before, and I really want to know, are we good stewards? Do we understand our spine? Do we understand the connection between our spine and the body and our brain?
Well, I'll tell you, as a medical student and somebody who's thinking about what kind of medicine to go into, the spine's pretty awesome. And so is the neurologic system. And
Okay.
the reason is because there are a lot of things you can do. You don't need an MRI scanner or a CT scanner or an X-ray to diagnose a lot of the things that go on with the spine, because the body is laid out in such a way that where the pain is and what type of pain it is or where the tingling is set up for a different part of the spine, a different part of the spinal cord, and a different part of the brain. So it attracts you because right out of the gate, there's diagnosis to be made based on things that you can physically examine in a patient or hear their story and make that diagnosis. So that initially attracted me to the nervous system and then the spine.
So one of the things I would love to know is, how do we avoid coming to see you, if I can do that? Can you give us sort of a spine overview and walk us through really what the spinal column is and all the different parts and pieces? That'll get us started.
Great. So that's really the function of the spine. So what is the function of the spine?
I feel like I should sit up
Yeah, me
straighter.
too.
Yeah. Well, the function of the spine basically is there are two different parts. Okay, the first part, or really three parts. Okay, but the first part of the function of the spine is every segment of the spine has to support everything that's above it. Correct.
Okay.
In other words, without a good spine, you can't stand up straight, you can't walk, your arms and your legs can't manipulate space.
Okay.
Right? It's like a crane. If the base of the crane doesn't work, well, then the arm of the crane is dysfunctional, and it's the same thing with the spine. The second function of the spine is it protects the neurologic system that takes the signals back and forth from the arms and legs, and not just the telling your arms and legs what to do, but also the sensations that come from the arms and the legs, and then what we all don't like to talk about,
Right.
the bowel and bladder function.
Sure.
The function of the things that are inside your abdominal cavity. They all have innervation, and so it carries those signals back and forth through the spinal cord and the nerves, and in addition to that, the spine has to protect the spinal cord and the nerves.
So what I hear you say, it's a protective piece of our body, and the neurological system is almost a feedback loop from our brain, the sensations, our organs, and then back up?
Now, I don't want to tell somebody who specializes in thought, which is what you do,
Yeah.
correct? All
Well, she has
about
a lot of
that.
thoughts.
But I'm a much more hardwired type of guy in that.
Okay,
And
okay.
that is exactly what it does, though. Without the spine functioning correctly and without a lot of pain, it's really hard to function as a person. And that can be anything from the extreme, which is paralysis, to just having some tingling in your finger.
So I want to follow that up a minute. What should I be doing? So I'm 64. What should I be doing in the morning? I stretch. You've got your model there, and it's mostly bones. I can't stretch my bones. I can't change the discs in between. And what do I need to do for back health, preventative back health?
That's a great question, and I get asked that question on a regular basis, especially in this area where these healthy people who have maintained their health into their 60s, they've worked hard at their job in Buffalo, and they've moved here, and they want to know how they can continue to be active and healthy and do all those things they moved here to do. So here's the answer to that. So the first thing is that it's hard to influence the aging of the spine.
It's hard to influence the aging of the spine.
Yeah.
Okay.
So one way to influence it is probably not to have been an athlete past 18, because it turns out that a lot of people who were, and I don't mean not staying in shape.
Okay.
I'm talking about being a competitive athlete at a high level in college or in professional sports. All the people who've done that, and I played college basketball, so I had to have my hip replaced at 53.
I remember this, yep.
Which made me a better doctor. But all the people who did that, they're starting a little bit behind the 8 ball. They're all getting their joints replaced 5 to 10 years earlier than the general population, in my opinion, and they have more problems with their spine. In addition to that, the one way to influence the health of your whole musculoskeletal system is to remain thin, eat right.
Okay.
Doesn't this sound just like every other doctor?
Yep.
So in this case, I'm just like every other doctor. But doing all those things, having a good exercise routine, and taking care of yourself in general, those will all influence the aging of your musculoskeletal system, including the spine.
And that is more of a middle path approach, though. It's not an extreme. It's not an all or nothing.
Well, in fact, the extremes are what get you, or what age the musculoskeletal system on both ends.
Okay.
Both the extreme of doing nothing and the extreme of being a professional athlete, for instance,
Got it.
where you continue to train and really pound your body into your late 20s or 30s. That both extremes, in my opinion, lead you to earlier musculoskeletal need for maintenance and then replacement of parts.
Do most people come to you or begin to even pay attention to their musculoskeletal system when they begin to feel pain?
It's usually pain, but for me, remember, I'm also a neurologic guy, right?
Okay,
so,
yep.
So it's numbness and tingling and dysfunction. So for instance, with neck problems, a lot of time the dysfunction is balance abnormality and difficulty using your hands for fine motor movements. So those are the things that lead to surgery on the neck, and we do quite a bit of surgery on the neck. We take care of the neck. That's a big part of my practice and Dr. Rubin's practice, who is my partner, as you know.
Yeah.
And so it's dysfunction, it's neurologic dysfunction, but pain goes with that, and it's frequently, I would say pain's the most frequent cause of coming to see me.
Pain in the neck. So what happens when you get a pain in the neck? Tell me about the cervical, that area of my body. What can go wrong?
Well, so there are multiple things. So that's a great question. Why might you see me?
Yeah.
Well, why might you see me for your neck? So one thing is if you have a motorcycle accident or a motor vehicle accident,
Okay.
or a motorized scooter accident, right? So
Electric bike accident.
all of those things are things that lead to trauma, and trauma can bring you to see me. But
Okay.
here in this environment in Beaufort County, South Carolina, many of the traumas are treated elsewhere. So
Got
which
it.
is an important part of one of the things that I do is I decide whether you're appropriate to stay here or whether you need to go to somewhere bigger, Savannah or Charleston. You know, we work with Charleston a lot.
Yes.
MUSC does a great job there when you need them. But many things can be treated here, and trauma is one of the things that we do when it's appropriate. Otherwise, we can send it out. The second thing that may bring you to see me, and these are the drastic things that are the big deal, are tumors in the spine
Okay.
and things like that. I mean, those are big deals. But by far the most common thing that I take care of people for are the changes that happen with age. And you know, those are all the little things that we start to notice in our 40s, and just as a brief whisk from time to time. By the time we're in our 50s, we're thinking, wow, now I'm starting to understand what my dad said.
Yeah.
And then we get into our 60s and 70s, and we're like, wow, now I understand what my grandparents were
Right,
telling me.
exactly.
So, but those are the things that bring you to see me. So getting back to the neck.
Yeah.
The things that we treat in the neck are disc herniations.
What's a disc and what's a herniation?
So disc in the neck, and I'm going to introduce you to my friend Shorty here. This is Slim, and this is Shorty. Okay, so
And
these
for
are
all you people that are listening, he has a lovely representation of the neck. True?
True.
Okay.
These are the discs. Now, this particular model is probably 2/3 the size of a real person, but each of this is the base of the skull, and then these are the vertebral bodies, and those are the cylinders of bone that make up the front and the column of the spine.
What are they called again?
Vertebral bodies. Vertebral bodies. So that's the round cylinder on the front of the spine with the tube in the back carrying the spinal cord or the nerve roots.
Got it.
And in the neck, it's the spinal cord. And the disc are the shock absorbers. A lot of people like to think about them as a shock absorber that goes between each vertebral body or each cylinder of bone with the disc in between. And when the discs are young and healthy, which I haven't seen that in a long time in myself.
Okay.
But when they're young and healthy, they're a great shock absorber and they're very stabilized. And it's a little bit like having a radial tire glued to two oil drums. As long as the radial tire stays pumped up with air, it's a great shock absorber and it's very stabilized. But if you start to let the air out of the radial tire, you can imagine it moves abnormally. Now, once the motion between the two oil drums or vertebral bodies becomes abnormal, it causes all kind of things in the little joints in the back called the facet joints. And once that abnormal motion occurs, it begins to make the tube that carries the bone, that carries the spinal cord or the nerves, it makes that tube start to get smaller and smaller or constrict. So it's a little bit like taking a long, thin tube and starting to constrict it at multiple places. And when that occurs, that presses on the nerves, and that's what can lead to some of these abnormal feelings that we have in our arms and our legs. And that's what mostly leads to spine surgery. Now, it's important for me to say this right up front, because when you say, when your primary care provider says, I'm going to send you to the spine surgeon, everybody gets nervous. But what you should realize is that Dr. Rubin and I in our practice, we act more as shepherds or the quarterback, maybe because it's football season, right? So we act more as shepherds or the quarterback for the whole picture of your care, the vast majority of which is non-operative or does not include surgery.
Got
so
it.
Most
really
people
important
don't
takeaway.
Need spine surgery.
Okay, most
and that's
people.
Important.
Yeah, so if I might jump in, I'll real briefly tell my story. So I wake up one morning and I get in the shower and my hands are numb. By the time I got out of the shower, I couldn't button my shirt. I had no dexterity and no strength in my hands. Fortunately enough, Dr. Boatwright's partner was a friend of mine. I called him and he said, come into the office, and they looked at physical therapy first and then got
non-surgical
my scans back. You talked about pain being one of the driving factors. I never had one bit of pain, both before surgery and after. Mine was all numbness. Just the strength was gone.
And the inability to use your hands for fine motor movements.
Right.
That's the sine qua non of myelopathy, and it's different than sort of, I'm weak. It's not really a weakness. It's more of and this is a real word for medicine, although young children have sort of taken this word and made it something different. But spasticity, or being spastic, is the inability to control your fine motor movements, and it also contributes to balance problems, although it's the fine motor movements that are the problem. And if you had not had surgery, that is a progressive problem in most people, myelopathy is, and eventually you get to the point where you can't hold silverware.
Right.
So
yeah, so when I went in, they did the scans, I need surgery. So my spinal cord's being crimped by those bony part of the spine.
Yep.
Do you make the holes bigger? What exactly was done?
So I think that in your case, that what Dr. Rubin did was he took the disc out completely. Now, a lot of times we take a little bit of bone on either side, because what we're doing is we're taking the spot where the either bone spurs or disc or just the general constriction of that canal due to those changes in age and that include all of those things, the collapse of the disc, all that accordions down and makes that hole smaller. We take whatever it is that's pushing on the spinal cord out. Now, in the neck, we always reconstruct what we've removed, because obviously if you remove that piece of disc, you've got to put something back in its place, or the spine is even more unstable. So remember, the spine acts as a structure. Without its structural integrity, which is, just another way of saying it's that it's the spine of the crane. Without that, it becomes what we'll refer to as unstable, or it moves abnormally, and that leads to even more problems, including a lack of the ability to protect the spinal cord that's running down the back. And then you have that problem again. So he fused your spine together. Now, people get super nervous about fusing the spine.
What is that?
Well, that's when you take, after you've removed something, you make two bones into one by having new bone grow in the middle. And that's the beauty of the skeleton. The skeleton is the only tissue in the body, other than some rare instances of the liver, that will regenerate the same exact material, not scar material, but the same material that it uses to make itself and to perform its function. So you can make new bone, and of course, obviously we came to be in such a way that was the case, because as children we break our bones all the time, and as adults we break our bones, and without your bones reforming in the same structural manner, you can't continue to get around and do all the things we're talking about here. So that's the beauty that's what a fusion is. It makes new bone.
Can you reinflate a disc that isn't mushy anymore? That isn't?
No.
Okay.
But I will tell you that is one of our dreams in spine surgery, is to be able to cause the disc to reform in the same functional manner that you had when you were 18. But and again, that's where things like stem cells and all those type of things may eventually be the answer to that. But right now, we are a long, long way away from that being the answer.
Doesn't everybody get degenerative disc disease as you get older? Everybody.
Correct.
That's why you get shorter, right? And that's your whole spine, right?
Yes.
Top to bottom.
Do we really get shorter?
We do.
Really?
So yes, I hate
used to be
that.
6'4".
Yeah. Well,
No, I'm 72 and I'm still 5'3". Or maybe I just wear bigger shoes now, or thicker socks.
Maybe.
That'll work. Ask Prince. So for me, there are basketball programs out there that list me at 6'2". Now those were always a lie, but I was 6 feet, and now I'm 5'11", and my children like to tell me I'm 5'10", because they're all taller than me.
Kids.
So yeah,
So exponentially, since you've begun practice, there is still a lot on the horizon for spine treatment, spine interventions, spine surgery.
That's a great question. And so I've practiced for 25 years after completing 15 years of training. So I started practicing spine surgery in my early mid-30s, and I'm in my late 50s.
Okay.
And so I've got a lot of experience. I've seen a lot of changes. I've seen a lot of things come and go in spine surgery. And what I will say is that the things I learned in the late 90s are in late 1990s, the themes are still exactly the same.
Interesting.
The themes are take pressure off the nerves,
Okay.
and restore the ability of the spine to function structurally. Okay, so we're rebuild the spine in the sense that it has to maintain appropriate structure in order to support the rest of the body, correct? And it also has to protect the nerves, the spinal cord or the nerves, and allow them to function appropriately. So those same things the theme of our talk here is the function of the spine, and those are the things that we restore. But the way we do it now, we've gotten much, much better at it in the last 25 years. And the places that we've improved are, for instance, restoring the structure of the spine by fusing the spine together. We have gotten way better at that. There is a medical device, they call it, but really what it is it's a protein molecule called bone morphogenic protein 2, which is very good at making bone form. So it occasionally is utilized for fractures that won't heal, but in the spine, it was developed by a spine surgeon. In fact, by my mentor, Scott Bowden in Atlanta at Emory. He was one of the primary developers of this, and in fact, it's the most successful medical device ever made because it gets utilized a lot, but it causes bone to form. So we've gotten way better. We don't have to take a bone graft anymore. 30 years ago, if you talk to a spine surgeon about what they were going to do in the lumbar spine, they would explain the surgery, and then they would say, and we're going to tunnel over, and off the back of your pelvis, we're going to take some bone, and then we're going to use that to have the bone form in the spine. But in today's world, you can utilize bone morphogenic protein instead. So, and that's a huge advantage. It cuts 30 minutes to 45 minutes off the surgery. It stops the amount of blood loss, a tremendous amount. So, that taking the bone off the pelvis or the bone graft was a fairly bloody thing to do. And, so we've made tremendous inroads there. And with respect to approaching the spine, we've made a lot of inroads there. We do a lot of what we call minimally invasive spine surgery now. Now, there again, like many things, there have been starts and stops on these things, and some of the things that we have done turn out to be technology over reason.
Got it.
But a lot of the things that we've done have made spine surgery easier to get over and less destructive on the way to getting to the spine. But the basic things that we do, taking pressure off the nerves and the spinal cord and then rebuilding the spine, are still exactly the same in the big overview as they were in the 1990s.
Dr. Boatwright, it's been a real pleasure to kind of introduce our listeners to you and your knowledge and the spine. And I think it's funny, as we've talked, it's almost foundational. We start at the beginning and we build and we build and we build. And the more we talk, the more we have questions to ask. So we're very grateful for your time today.
Of course.
We love takeaways, and I think we got some really specific takeaways for Mind Your Health. So again, thank you for joining us. Thank you all for joining us here on Mind Your Health.
Claire.
Well,
You are great. Now we